Welcome to Ask an Expert with Ask Resource Center. We're so excited to share with you Teresa Bomhoff tonight. We've done a series around IEPs, behavior through the month of April, and Teresa is now our next expert that we've asked to come to the table with us. And she's a board member at MindSpnng Mental Health Alliance, and they were formerly called NAMI, and she has been very active in the world around mental health and helping and unlayering what those supports look like. So this evening, Teresa is going to walk us through some things that we can probably all take away of how we can help ourselves and help our family members. So Teresa, welcome to Ask Resource, Ask an Expert, and we're going to turn it over to you.
Well, thank you. My name is Teresa Bomhoff, and I happen to be the mother of 2 adults with serious mental illness. I am a board member of MindSpnng Mental Health Alliance, but I also worked for 39 years for USDA Rural Development, and I retired in 2011. Our nonprofit charitable organization, MindSpnng Mental Health Alliance, was formerly known as NAMI Greater Des Moines. We did a name change, and our purpose is still to provide education and support and advocacy for persons with mental illness, their families, and the community. There's 2 statements, I guess, that I need to start off with. And the first is that we need to treat brain health issues the same way we treat heart disease, cancer, diabetes, and any other physical disease. Second statement, we want to end the stigma of mental illness by changing the words we use. So, psycho, crazy, nuts, all those types of negative words need to be thrown out. And even mental illness should eventually be replaced with brain health or brain disease. First of all, let's define mental illness. First of all, it's a medical illness, and you can call it also a brain disorder. And it affects our thinking, it affects someone's emotional state, and it affects their behavior. It also disrupts the person's ability to work, to carry out daily activities, and engage in satisfying relationships. Now, when you think about it, the brain is the most complex part of the human body. This 3-pound organ is the seat of intelligence. It's the interpreter of the senses. It's an initiator of body movement, and it's the controller of behavior. Lying in its bony shell and washed by protective fluid, the brain is the source of all the qualities that define our humanity. The brain is the crown jewel of the human body. Brain disease is not a choice. 1 in 5 people have experienced a brain health issue in their lives, and that's roughly 500,000 people in Iowa alone. So the brain is the control center for the entire body. Therefore, when it is not working correctly, it can affect thinking, emotional state, and behavior. And this medical illness also affects the entire body, not only emotions, thoughts, and behavior, but all other physical activities that are going on in your body. I've had the unlucky experience of having depression myself, and it was one of the most physically exhausting and emotionally depleting times in my life. And the difference between experiencing, say, the blues or having the blues and having a disorder is due to the severity of symptoms, the duration of the symptoms, and the impact on one's life. So in the case of depression, if you have things that impact your life for a minimum of 2 weeks, you really should get in to see someone and get some treatment going. So why do people have mental illnesses? Well, you can see on this drawing, there's biological susceptibility and there's environmental factors. So we'll talk about that a little bit. If you're genetically predisposed, emerging symptoms of mental illness may appear. Now, they thought that in the beginning, when they started studying the brain out at the National Institute of Mental Health, they did a study that proved that mental illnesses were not totally inheritable. And what they did is a study of identical twins. And with identical twins, you have identical DNA. And what they found out, there were too many instances where one twin would develop schizophrenia and the other one would not. So that's why they knew it was not totally inherited. that you had a genetic predisposition and something in the environment would kick it off. Keep in mind that brains don't finish developing and completing neural circuitry until age 25. The last portion to develop fully is the frontal cortex, the location of decision making. And along the way and all that, there's also puberty and hormones, which can affect it. And then you have what I call a real petri dish. So why do people have mental illnesses? Once again, they combine both biological susceptibility and environmental factors combine to disrupt neural circuits in the brain. Keep in mind that genetic does not mean inherited, because actually spontaneous mutations in DNA are common. They have found families where they've never had mental illness, in generations. It's just popped up. And they call that a spontaneous mutation. Dr. Thomas Insel, who was a former director of the National Institute of Mental Health, had this discussion in one of his blogs. He said, "We think of dealing with mental illnesses in terms of behavioral and psychological solutions. We need to address them from a biological standpoint as well. Most research is centered around trying to understand how medications work with natural brain chemicals. But we also need to understand how brain circuits are involved and the molecular and cellular changes that are involved. So for many of these, they are neurodevelopmental problems. They all begin early in development, many years before you see the behavioral changes. During the growing up years, once again, puberty and hormones influence the process. For schizophrenia, which is probably many different disorders, the development of psychosis is a very late stage. By the time someone at age 19 has a psychotic break, you are seeing the end product of many years of changes that we simply have not detected and have not begun to intervene with. We need to figure out interventions at different stages of development to minimize the disability. In other words, we need to step up prevention and early intervention. We need to understand both the genetic and environmental factors that feed into mental disorders. There is a relationship between genetic risk and experience and environment and family history. So this slide shows another perspective in the causes of brain disorders. It once again helps to explain the triangle of causes you saw earlier. Some causes could be a genetic predisposition, some are environmental. And so the first item listed on the slide are when you have a genetic predisposition. Some examples of that are Tourette syndrome or bipolar or schizophrenia. The second cause of disabling brain disorders are caused by brain injury. It could be a car accident, a seizure, other illnesses, high fevers, a fall, oxygen deprivation, and multiple hits in sports activities like the NFL players are now being diagnosed with. A third cause of disabling brain disorders are caused by trauma. For some people, the death of a parent can really spiral them out of control. A natural disaster and trying to recover from everything that's been destroyed. Bullying, abuse. And I would certainly suggest that you all read a report. It's the 2020 ACEs report. And on the slide, it gives you the website where you can find it. It explains what adverse childhood experiences are. And if those are not addressed, it can leave a person with a susceptibility for depression and other chronic illnesses in adulthood. ACEs can be abuse, either sexual, emotional, or physical, neglect, substance abuse in the household, untreated mental illness in the household, observing domestic abuse in the household, or having a parent in prison. More and more, they are sending these questionnaires out to see how pervasive adverse childhood experiences are in different populations. Protective factors have also been identified to lessen the impact of ACEs. There are steps which can be taken to increase resilience in kids and adults to offset the effects of adverse childhood experiences. A lot of people call it trauma-informed care, something that Oprah happens to be championing right now. I don't know whether you've seen some of her commercials, but she says that she's talked about different traumatic experiences that she had as a child and how that shaped her. And it's something that she'll be talking more about. So brain disorders are a public health issue, for everyone. Major mental illnesses. These are the different categories. I think anxiety disorder is the most prevalent. The second highest is substance use disorder, and the third is major depressive disorder. I will point out that the number that's for schizophrenia is an error, because we found out how they came up with that number, and they excluded way too many people that were homeless or in institutions and so forth. The actual number is 1.1%. If you look at anxiety disorders, that contains a lot of subcategories like social anxiety, generalized anxiety disorder, obsessive compulsive disorder, panic disorder, PTSD, specific phobias like being afraid of walking under ladders, being afraid of spiders, so forth. And then there's agoraphobia, which is the type of anxiety disorder which prevents you from leaving your house. You're basically homebound because of your anxiety. Another fact that I thought you'd be interested in, the median age of onset for an anxiety disorder is 11 years old. This means people have their first episode of an anxiety disorder by this age. And with the World Health Organization, they have compared the relative impact of different illnesses across the world. According to them, mental disorders rank as the biggest health problem in North America and are ahead of both cardiovascular disease and cancer. And the major impact of mental illness is not so much because it causes premature death, but because it causes disability. And the definition of disability, if you think back to the very first slide when I talked about the definition, it refers to the amount of impact or disruption affecting the person's ability to work, carry out daily activities, and engage in satisfying relationships. Okay, research has proved that brain disease is caused by malfunctioning connections between nerve cells along pathways in the brain. And you'll see 3 pictures on this slide that show how MRI technology is now able to identify areas of the brain that have been compromised by brain disease. I was asked if they were using MRIs to diagnose, and I have to say no, I'm not aware of that. It gives, when they see enough MRIs and they compare it to what people's diagnoses are, they pretty much know what to look for, I guess is a better way to look at it. But I want to share once again that it's normal for a person to feel sad every once in a while, or frustrated by health problems, or financial concerns, or have the blues. Now, if one of the following symptoms persists and interferes with your daily life, you could be suffering from a mental illness or brain disease. So I'm going to quickly go through these. Feeling sad or down, confused thinking or reduced ability to concentrate, excessive fears or worries or extreme feelings of guilt, extreme mood changes of highs and lows, withdrawal from friends and activities, significant tiredness, low energy or problem sleeping, detachment from reality, also called delusions, paranoia, or hallucinations. Here's some more. Inability to cope with daily problems or stress, trouble understanding and relating to situations and to people, problems with alcohol or drug use, major changes in eating habits, sex drive changes. One sign or symptom of people in a mania status in bipolar is that sometimes they become hypersexualized and just become another person, and it causes great problems for them. Excessive anger, hostility or violence, suicidal thinking. So once again, mental illness is not just emotions. It is a physical illness. The brain is ill. The body can have significant symptoms too. In depression, you feel like you have a worse case of the flu. Everything aches, everything hurts. In the manic phase of bipolar, you feel invincible and you can stay up and active for days at a time. So who can diagnose a mental illness and prescribe both of those things? Well, first of all, surely psychiatrists, and you knew that. We only have 216 psychiatrists in Iowa. About 150 of them are in private practice or in a location where people like you and I could reach them and have an appointment. The other ones are teachers in administration or in federal or state institutions. So once again, for 3.17 million people, we have basically 150 psychiatrists who can diagnose and prescribe. There's also primary care physicians, except some primary care physicians do not feel comfortable dealing with mental illnesses. And so they've either referred them right away to a psychiatrist, or they might have established a relationship with a psychiatrist in another location whom they call to get advice when they have something happen that they need to get some advice on. And relatively recently, there are family practice doctors going through their residency who are also taking psych courses because they know that that will help them in their practice. So the third type of medical professional who can both diagnose and prescribe are advanced nurse practitioners. And there's only 226 in the state who have specialized in psychiatry. Physician assistants who have specialized in psychiatry can also diagnose and prescribe. We only have 46 of those. So they've been concentrating on trying to get that workforce built up. And we're slowly getting more people, but we also need direct care professionals. We need social workers. There's nearly every type of mental health practitioner is needed in Iowa. When you talk about treatment can include medications or talk therapy or a combination of the two. And I can't say this often enough. If you or your loved one shows signs of disease, seek treatment. Left untreated, mental illness can affect one's physical health and quality of life. Why do we have reasons for low treatment rate for mental illness? Well, lots of times you don't know who to look for, or if you know who you need to go see, they may not be available for 60, 90, 120 days for an appointment. So that's one reason. In fact, statistics on this are that 60% of adults and 50% of youth ages 8 to 15 avoid treatment or do not ask for help with brain issues. Sometimes it's because the symptoms are not recognized. Sometimes you're too busy to notice. Sometimes you may notice, but you're in denial. You don't want that to be the problem. You want it to be something else. There's also the widespread belief that nothing can be done. Some people still believe that mental illness is not real. The belief for people who are old and sick is that old and sick people have reason to be depressed. A big mistake. Their lives can be so much better with treatment. It is not a given that depression always has to go along with aging. Some may feel shame for needing help with a mental health problem. Some, because of the stigma, they may not want to tell anyone about what they're going through. They may not have insurance or do not think insurance will pay enough of the cost. They may just not know what to do and where to go. One of the problems, for instance, in diagnosing depression, because some symptoms of depression are similar to dementia. So in both of those cases, there's memory loss, neglect of personal appearance, irritability or anxiety, pacing and fidgeting, and lack of energy. So once again, an accurate diagnosis is critical. Having a thorough physical can rule out reasons why you may not be feeling well. I've been told by I don't know how many nursing staff, and doctors, and people on the mobile crisis team that when they bring in older women who are acting erratically, the first thing they do is check for a urinary tract infection, because for some reason that really sends people on a spiral, and they think it's, the tendency is to think it's a mental illness when it may be correcting the infection where things can go back to normal. Somebody asked me if that was true for men too, and I don't know, but I've never had anybody tell me about a situation with a male. Now, some of you wanted to talk about self-injury or self-harm. And the first thing I want to tell you is that self-injury or self-harm is not a mental illness. It's a behavior. It's often a symptom of a mental illness. It can become addictive. The intention is to harm self, not kill self. All ages of people self-harm. All people who self-harm deserve proper medical attention. I have personal knowledge of people, and it's usually younger people they pull this on. They go into the emergency room, and if they've been there too many times for self-injury, comes a point where they just don't give them anesthetic when they sew them up or treat the wound. I personally didn't have an experience with it, but the first time I heard of it was probably about 10 years ago, and I thought for sure somebody had done something about that. But when I used to teach mental health first aid to nursing students, I had people who were doing nursing stints in ERs for part of their jobs, and they said that it was still taking place. So I'm hoping that somehow that gets eradicated, that everybody can get the proper medical attention they need. And a lot of people think that people who self-harm are attention seekers, but that's really not the right term to use. It's more that they are attention needers, because they may not have the words to communicate their needs, and they may feel they don't have anybody to confide in. Self-injury is more than cutting or burning or things that we can see. It can also include excessive exercise or pinching oneself, increased drinking, overdose with non-fatal intention, hair pulling, staying with people who treat you terribly, and sabotaging good relationships. And if the self-harm, and you need to seek emergency medical help when someone has taken an overdose of medication, if they've consumed poison, if they've sustained a life-threatening injury, if they're confused, disoriented, or unconscious, and certainly if they're actively bleeding. And it's especially serious if it's rapid bleeding or pulsing bleeding. So what are the reasons for self-harm? Well, in working with a group of people who self-injured, some of it described as to escape unbearable anguish, having a problem they did not know how to resolve, and they were caught, frustrated, to change the behavior of others, to escape a situation, or to show desperation to others. Maybe they don't have the words to approach a parent for how badly they feel, or to show their friends or teachers, to get back at other people, to gain relief from tension. Sometimes it's to seek help. Once again, if they don't have the language to do that, they'll try to find some other way to express it. And if they don't have the coping skills, that's what they need to work on. So how to help? First of all, recognize that self-injury is usually a symptom of serious psychological distress. You should avoid any negative reactions to the self-injury. As much as you'd like to scream, just don't. You have to stay calm, and you discuss the situation calmly. And rather than focusing on hiding the tools of their self-injury, the only way that this is going to be helped and stopped is to focus on ways to stop whatever is distressing them. You do not focus on stopping the self-injury, because only the person who's doing it can make the decisions to stop. Don't trivialize their feelings or the situations that have led to self-injury. It really doesn't make any difference what you think about it. The fact is that that person feels so badly about something that they're hurting themselves in order to show that they need help. Don't punish the person, and do not threaten to withdraw care. Once again, removing the tools for self-harm will not stop the behavior. They'll just find something else. The source of the distress should be identified and additional coping strategies learned. The person who self-injures has to learn other ways of coping. Self-harmers often say that there is a buildup of pressure. Harming can be like opening the lid of a boiling pot to give some release. Someone described to me once it was, once they saw the blood flow, they knew they were still alive. So it can temporarily be a relief until, again, new coping strategies are learned or an underlying mental health problem is treated. And this information that I gave to you about self-harm is from the mental health first aid course. So now we're going to talk about crises. And MindSpnng has 3 crisis cards, and I thought I'd start with this one. But just to preface this, all these communication cards we have for sale. And what we do is you can order them online. They are all wallet size, so you can carry them around with you anytime. You can personalize them, you can put your organization name on, your website, your street address, I guess any identifying information you want to give. I thought I would start with the compassionate communication card because this, I think, is a preventative card. It's a way to avoid problems or escalation of the mental illness. You'll notice on the left-hand side, there are three things that I always say. I always have to remind myself, too, that you are not alone. There are a lot of other people who have the illness. There are a lot of people that are there just waiting to help you. The illness is not your fault. I mean, a brain, when you have a disease, that's not anybody's fault. Never give up hope. Even though progress may be slow toward recovery, with baby steps, I think is what was in one movie that I saw. You have to take baby steps in order to get to recovery. Then you look on the back side of the card, and the big thing on it, it says, guard your temper. That is really something that you have to work on doing. You don't nag, you don't yell, and you don't argue. Focus on the person you know and love, and provide reassurance generously and often. And we've even given some ideas on what you can say, because these are things that people really need to hear instead of the cross words. For instance, I love you and I care. You're not alone in this. I'm sorry you're in so much pain. I'm always willing to listen. I'll be your friend no matter what. This will pass, and we can ride it out together. You are important to me. When this is all over, I'll still be here. These are good tips actually to follow in communicating with a person with a brain disorder, or anyone else for that matter. It's just good, compassionate communication to have. A key is listening non-judgmentally to them. And I should go through some nonverbal skills that you should be aware of, or cues, because nonverbal cues are important. First of all, attentiveness. At least, look like you're interested in what they are saying. Have comfortable eye contact. Don't stare at them. Sometimes if things seem to be getting a little testy, what helps is to just have a seat. And maybe they will lower their voice or want to have a conversation with you. So they may be seated next to you. And you sit next to the person rather than opposite them, because then cannot be confused with being adversarial. There are attitudes that you want to have to make the person feel respected, accepted, and understood. And that's acceptance, genuineness, and empathy. Even your facial expression. You need to be aware of what your facial expression is like, because people can tell if you're being dismissive or they don't really care about you just by looking at your face. The tone of your voice is also a dead giveaway. And these kind of communication skills, I think, will help to prevent a lot of situations. The second crisis card that we have, it's called Do's and Don'ts of a Mental Health Crisis, when you're trying to communicate with someone who has a psychiatric illness and they're in crisis. The overall thing that I want to say to you is that these are ways that you can de-escalate instead of escalating a situation. These are the same cards that the Des Moines police use. We give them to all kinds of law enforcement classes where we participate in crisis intervention training. So it's the same thing that they learn. Okay, so first of all, slow down and give them space. Their thinking is compromised. They may be panicky, depending if they're seeing things, hearing things, feeling things on their skin, tasting things. I mean, all five senses can be affected when you're having a psychiatric crisis. Be calm. Express support and concern. Be calm is something, once again, that you will find over and over and over again in crisis situations. Speak slowly and softly and use short, simple sentences. You don't know what could be interfering with their ability to understand you. Once again, if they have voices that are coming to them, if they're seeing things that you're not seeing, that all interferes with being able to hear yet another stimuli from you. Avoid sudden or quick movements because, once again, they're not sure of what they're seeing. So you don't want to frighten them. Be helpful. Respond to basic needs. Be low key. We are all here to help. Give firm, clear directions. Only one person should talk to them. Respond to delusions or hallucinations by talking about their feelings, not about what he or she is saying. They will say things that could be that you might want to take personally, but you shouldn't. It's the illness talking. And the only way you can really successfully converse with them is to always just respond about their feelings. An example would be, it must be terrifying to think your family is in danger or are being hurt. That would be one example. Do listen to their story. Do explain policy. This is for cops, especially if handcuffed. Then we go to the don't side. Don't take control if you don't have to. Don't argue or reason with psychotic thinking. You'll never win. Not that they're right and you're wrong. It's just that it's a useless thing to get involved in. It won't improve the situation. It'll only make it worse. Don't stare at the subject. Once again, have a comfortable eye contact. Don't confuse the subject. One person, once again, should interact with the subject. Others should keep their distance. Ask casual observers to leave. The last thing that the person needs that's ill is to have a bunch of people gawking at them and talking, having their hand up to their mouth and talking so that they think that they can't hear, that kind of thing. And try to follow through with any directions or commands that you've given them. Don't touch the subject unless necessary, especially if they're not expecting it. You should always ask permission to touch them or warn them that you're going to touch them, because for people with mental illnesses, it may cause fear and lead to violence, because once again, they may not know who's in front of them and they're going to react to protect themselves. Don't shout. Once again, it just is part of the sensory stimuli that's bombarding them. Don't give them multiple choices because it can increase the subject's confusion. For heaven's sake, don't whisper, joke, or laugh at them. They may be ill, but they can still feel humiliation, and it will escalate the situation. Don't deceive the subject. Dishonesty increases fear and suspicion. The subject will likely remember it any subsequent contact. They won't trust you. This again is for police. Don't arrest a person for mentally ill behavior, not criminal in nature. Don't join into behavior related to the person's mental illness. And if a person has to be restrained, don't hogtie them. Lots of times they will put people on their stomach and put their hands in handcuffs behind their back, but they should immediately then raise him or her from prone into a sitting position, monitor their vital signs, and call for medical aid. Now, once again, the whole reason for taking these steps is to make sure the situation can be de-escalated. You don't want to do anything to escalate it. The third card is on suicide. And I'm just going to have some statements first, overall. First of all, if you are concerned about suicide, let the person know you are concerned and that you're willing to help. Express empathy for what the person is going through. Encourage the person to do most of the talking. Somewhere along in the conversation, you might say that thoughts of suicide are often associated with a treatable illness. Another thing is that thoughts of suicide are common and do not have to be acted on. And there are two common myths surrounding talking about suicide with someone in distress. Myth number one is asking about suicide will put the idea in the person's mind. Not true. Myth number two, someone who talks about suicide isn't really serious. Once again, Not true. The fact is, talking about suicide may be a way for the person to indicate just how bad he or she is feeling. So let's take a look at the suicide warning signs first. If they're talking about wanting to die or to kill oneself, if they're writing notes or poems about death, looking for a way to kill oneself, such as searching online or buying a gun, talking about feeling hopeless or having no reason to live, talking about feeling trapped or in unbearable pain, talking about being a burden to others, increasing use of alcohol or drugs, deterioration in performance in daily life roles, acting anxious or agitated, behaving recklessly, sleeping too little or too much, withdrawing or feeling isolated due to a change in relationships, showing rage or talking about seeking revenge, displaying extreme mood swings or a sudden change in personality, and overt signs of depression like neglect of appearance, self-mutilation, crying, giving away items, visiting or calling people to say goodbye. And the risk is going to be greater if a behavior is new or has increased, and if it seems related to a painful event, a loss, or a change. So now you go to the other side of the card and you've recognized signs of emotional suffering. And once again, express concern, offer support, and listen non-judgmentally. They don't need you moralizing to them. Listen non-judgmentally. You ask, there's the question that you have to ask directly. You do it in a private setting, and you do it in a calm way, not with a lot of drama. And in a private setting, that means the two of you in a room or someplace where you can have some privacy. You don't do it at the supper table. You don't do it in the middle of a group of friends. You don't do it at a family gathering. You don't do it in the school hall. It has to be a private setting. So you have to ask one or both questions. Are you having thoughts of suicide? Once again, you have to say it calmly. Are you thinking of killing yourself? Without drama. Say it without drama. Now, if the answer is yes, you have the choice of asking additional questions if you want. Have you decided how you are going to kill yourself? Have you decided when you would do it? Have you collected the things you need to carry out your plan? And once you know that they are actually thinking of killing themselves, you have to care enough to keep that person safe. At the point where they indicate that they are suicidal, you do not leave them alone. You do not use guilt or threats to stop suicide, such as, oh, you're going to go to hell, or you will ruin other people's lives if you die by suicide. Once again, it's not helpful. It's only going to make things worse. And they'll probably walk away, never trust you, never talk to you again. You don't want that to happen, especially in the state they're in. You calmly listen to them. Most of all, don't agree to keep it a secret. And that is a problem for peers, for kids the same age, if it's a child or a youth. They just can't keep it a secret. This is one thing they don't do that with. And then you need to text or call a number for extra support. Now, it might be talking and getting some advice. And there's a national lifeline number that's on the card. And there's a national text number where you can text for help. You can talk to them to ask for assistance and what to do, or maybe the person that's suicidal can talk to them. If you think you can get them in the car safely and safely transport them to a place for them to get professional help, I'm sure that's okay. If you do not think that you can transport somebody, and especially if there's imminent danger to you or anybody else and to the person who's ill, call 911 for a transport for professional help. And keep in mind that you need to give enough information to the 911 dispatchers so they know what's going on, who is in crisis, and what's going on. And you just, if you need transport, you ask them for transport. Police will be the first to show up, and they will want to make sure that the situation is safe. And if they think that the mobile crisis team needs to be called, then they will call them, indicate that they need to arrive. Now, I will tell you that Polk County Health Services has to have children's services in place by July 1st. And we have a flow chart. I didn't decide to share it because it's a draft. But basically, there's going to be two ways that you're going to be able to seek assistance. And one is if there's imminent danger, you're going to have to call 911, a social worker. We hope to have a social worker with the dispatch so that they can help make decisions on what the next step is. But it will definitely include having the police arrive first. The other way that it can go is that if it's not imminent danger, but somebody is in distress and needs to see somebody, you can call Your Life Iowa and talk to the warm line, and you can discuss the situation with them. And the plan is that there will be a second type of mobile crisis. It's actually called crisis stabilization services. And that's when two people who have knowledge of child mental health, child and youth mental health, they come to the house and work with the family, with the individual and the family to try to resolve the situation. And in their assessment, they decide, where it would be an appropriate placement or whether it can be resolved there at home. And looking at statistics for the mobile crisis teams, right now, there's only one mobile crisis team, and they get about 2,600 calls a year. About 40% are resolved in the field. There's only 1% go to jail. I can't remember I think maybe 11%. That's the number that sticks in my head. I hope it's right. About 11% are hospitalized, but they could also go to the crisis observation center or the urgent care. But all this stuff is going to be in a big flow chart so that people know what to do for sure. And like I said, the children's services are supposed to be in place by July 1st. To go on, having depressive symptoms certainly increases the risk of suicide for a person because the person may feel so overwhelmed and helpless about life events that the future appears hopeless. However, not everyone with depression will be suicidal. You need to know that males complete suicide 4 times more often than females, and females attempt suicide 2 to 3 times more often than males. Suicide is now the first cause of injury deaths, followed by car crashes, poisoning, falls, and murder. Worldwide, there's over 800,000 suicides every year. Nationally, the high is about 47,000, over 47,000 suicide deaths. And in Iowa, our numbers have continued to grow. We are up to 550 suicides in Iowa per year, compared to less than 50 homicides. So we really do have a significant problem with suicide. And then we also have opioid deaths, and those are rough. Last year it was 208. So after this slide, we have one more slide. I always like to have this as one of the slides because it helped me kind of encapsulate all that goes into stigma. First of all, brain disorders are not a defect in someone's personality or a personality flaw or a sign of weakness. It is not a sign of laziness or a lack of willpower or a sign of poor moral character. It is not a sign of lack of faith, nor that the person is a failure. They are ill. They are medically ill. And for the last slide, I've given you our website. If you're looking for some education classes, we have right now probably about 30 one-hour classes that we schedule. Right now it's 2 a week, and they're for an hour. Don't cost anything. They're all free. In fact, when we fundraise, it's so that we can offer all of our classes free. We will soon have a series of workplace education classes also. about the same number. And we will continue to develop new classes based on input that we receive from the public. I also encourage you to sign up for our monthly newsletter. I have lots of information in it. It has all the crisis services. I list community mental health centers, where mental health offices are in each county. There's about 3 or 4 sets of suicide and warm lines. I don't know whether you knew it, but there's free services also offered through FEMA dollars through COVID Iowa recovery resources. I have those all listed in the newsletter too. A lot of Facebook activities, and they have a warm line and the Iowa Concern line also. There's a few providers I list, information for the LGBTQ community, as well as African American community. And then I just have a series of articles that I think people would like to know about. And the main newsletter, which is on our website right now, I did a series of articles on teenagers and mental health, which I thought was well done. What I do is I find articles that I think are great, and I put them in the newsletter and always give credit to wherever I find the article. If you want to sign up for the newsletter, sign up is also on the homepage. And if you have any questions, I'd be glad to answer them. But I want to certainly thank you for inviting me to talk tonight. And I certainly hope that this information is a help to you.
Well, thank you, Teresa. It's been very eye-opening. Wow, the number of providers, I'm shocked. 200. I mean, it's definitely very much a weakness in our state. So really good information about just the reminders of how to not make this a stigma or draw attention to it in a way that makes it worse. So I love the cards, and your information was very, very helpful. We didn't have any questions tonight, but you were very thorough in everything that you provided. So we want to thank you again for Ask an Expert, MindSpnng Mental Health Alliance with Teresa Bomhoff. And we appreciate your time tonight. Thank you, Teresa.
Yes, thank you.